Can I please request Dr. Dhanashree to please join us on the stage? So next, I think moving on from understanding how to go in for the case, I think then comes the big debate whether to go unimanual or bimanuals, which are the two ways of dissection. And nobody better than Dr. Sangeet Mittal can help us with this converse dissection, unimanual rocks. Dr. Sangeet Mittal is a chief vitreoretina surgeon at Thindai Hospital, and I think his knowledge on the subject, has corresponded to the number of awards that he's won through his career. Very illustrious career, and we are very happy to have him here.
Thank you, Dr. Gagan, for including me in this course. And my topic for today is this converse dissection unimanual rocks. Actually, I've been propagating this technique for past 10-15 years, and it's always been a controversial, but I'm very happy using it. I'll just the slides.
Slides or not?
So we, as in the previous presentation also, we learned that the new vessels grow along the trampoline-like contour of the posterior hyaloid, using it as a scaffold, and they progress to form epiretinal membranes, which are fibrovascular and contractile, and combined with the anterior posterior traction of vitreous on all sides, it gives an appearance of a tabletop TRDs. And it's difficult to treat these membranes. It's not just like a simple ERM that you just go and peel it off. Because these membranes are not glued, it's not like a paste over there, but they are nailed at various epicenters, as Dr. Dries has shown in his previous presentations. At multiple epicenters it is nailed, so you have to go cut one by one all these nails. And limitations of the current techniques which we use are segmentation, delamination, and the en bloc dissection. There are some limitations, like in segmentation, delamination, usually you need fourth port or combination instruments. And in en bloc dissection also, it's very difficult. It's not possible in all cases. And finding proper plane of dissection remains a challenge in both these techniques. So from our past experience, we have observed that dissections of membrane is, first thing, this is very important, that dissection of membranes is very easy if you have a proper plane of dissection. And as Dr. Dries in his previous presentation showed, that vitroschisis causes second membranes under the prominent membranes. And all these membranes, whether second or third, they are all usually fused with the primary membrane at the optic nerve head. And it's always easier to work around the tractional points than to cut or peel them. I generally use 27 gauge vitrectomy, but for diabetic patients, but it's any small gauge vitrectomy, either 25 or 27. It's an advantage because they have a low flow rate and there's low turbulence and more stable retina while working close to it. They have a very small sphere of influence, and it avoids retinal tissue being engaged in the cutter while dissecting the membranes. And the small size of the cutter allows it to go even in very small gaps that are present in various nails for effective membrane dissection. The opening is larger and nearer to the tip, so you can grasp or peel and dissect the membranes with the cutter itself, and you don't need extra instruments for that. And what the technique that I'm discussing with you is what we call that modified en bloc surgical technique. You do a core vitrectomy, you detach the posterior hyaloid at the disc and then dissect the membranes at epicenters using vitreous as a second instrument. So a small animation to depict what is done. So, okay, so this is a live demonstration. Just go at the optic nerve head and just pull these membranes up like this, and you will get a very proper, good plane of dissection for the membrane dissection. The concerns while we are using this technique is, the foremost concern is that the NVD will bleed profusely. The optic nerve head will start bleeding and you will not be able to do anything. But our observation is it is very uncommon. It's not that every patient is going to bleed. Preoperative anti-VEGF also helps in minimizing the risk. And if it starts bleeding, if you feel that it starts bleeding, just don't panic. Just stop for 3 minutes. 3 minutes is the time. 3 minutes, and just close your eye, and the bleeding will stop automatically. There will not be much blood and it won't bleed again. And once you have stopped, you don't remove the clot from the optic nerve head. Just let it remain over there. Another concern is that it can cause iatrogenic tears, but only if you pull too high and too heavy, these tears may happen. In severe cases with thin atrophic retina, you have to take care. And once you start doing it, you will automatically come to know how much pull you have to apply to avoid these type of complications. So this is a small video. And this is the membrane dissection part is totally unedited. And the patient had a lot of this membrane. So once I've separated the membrane from the disc, now you see it is totally unedited. I've not cut anything, only the speed is a little faster, two times in the interest of time. You just see I've separated the membrane of the disc. Now I advance my cutter, I cut the membrane like wedge and advance to the periphery from the center. And once I have reached the periphery, I start inducing the PVD from the periphery. And now I can go all around the epicenters to cut these, around epicenters to cut them all. So one by one, you can take all these epicenters one by one. So you can do a direct dissection, you can do a rollback dissection depending upon the membrane and the retina below. And you see such a big membrane, such a tough membrane. With this technique, you can dissect it very easily. So I'll show you another case whether just to see whether it works in combined retinal detachments or not. So again, this was a 27 gauge vitrectomy for a patient with PDR and combined retinal detachment. Just pick up the membrane from the disc, just create a wedge between the peripheral retina and the central retina. You just see and just start inducing the PVD in the periphery. Now this peripheral vitreous, it acts as a second hand. It just keeps your membrane taut up, acts like a second hand. What you want to achieve in a bimanual vitrectomy, you can just achieve by having this vitreous over there. And then you just go in and keep on dissecting this membrane easily. And the small gauge vitrectomy also helps because it keeps the retina very stable while you are doing this dissection. So this is 3 months post-op, the same eye. So I'll just skip these parts. I'll just skip the video, this video. Now the advantages of this technique is that it can be performed in all types of tractional detachments. Its surgical time is considerably reduced. Complication rate is again very low. Easy to perform peripheral, which acts as a third hand to keep the posterior membrane held up. Fourth port or combination instruments are not needed. Can be performed in the presence of vitreous hemorrhage. Can be done even in the absence of PVD. And second, membranes are not missed and need not be dissected separately. To conclude, around the table dissection of membranes using 27 gauge vitrectomy is a simple, faster and attractive option with less complications and can be performed in all types of tractional detachments. Thank you.